Hello, I'm Dr. David Fleischer from the University of Colorado School of Medicine, and today I'll be presenting a summary of our manuscript titled, Does Comorbid Food Allergy Affect Response to Omalizumab in Patients with Asthma? There's a well-established intrinsic link between asthma and food allergy. Indeed, approximately 20% of people with asthma also have food allergies, and comorbidity can exacerbate both conditions. For example, you may have worse asthma control, a higher likelihood of fatal reactions to food, and worse quality of life. Given that the pathophysiology of both asthma and food allergy can involve immunoglobulin E, or IgE, the anti-IgE antibody omalizumab has biological plausibility for managing both conditions. Indeed, omalizumab is now approved as a subcutaneous injection every 2 to 4 weeks for patients 6 years of age and older with moderate to severe allergic asthma, and in conjunction with food avoidance for patients 1 year of age and older for the reduction of type 1 allergic reactions, including anaphylaxis that may occur with accidental exposure to one or more foods. However, only a few small studies have assessed omalizumab in patients with comorbid asthma and food allergy. The objective of this analysis was to assess whether omalizumab could improve healthcare resource use, quality of life, productivity, and asthma for a spectrum of patients with asthma and food allergy. We conducted a post-hoc analysis of placebo-controlled randomized clinical trials, IA05 in children and 008/009 in adolescents and adults, and real-world observational studies, Prospero and Excels, that studied omalizumab for patients with asthma. For each study, patients were stratified by whether they had physician-reported food allergy. At baseline, we found that patients with food allergy were generally more atopic than patients without food allergy, with higher serum total Ig levels and higher rates of allergic comorbidities such as allergic rhinitis, atopic dermatitis, and urticaria. The main results of our study were that in patients with asthma, in both clinical trials and observational studies, omalizumab treatment led to significant improvements in healthcare resource use by emergency room visits, hospitalizations, unscheduled doctor visits, and steroid bursts, quality of life using the asthma-specific asthma quality of life questionnaire, productivity by school or work days in the work productivity and activity impairment asthma questionnaire, and asthma outcomes by asthma exacerbations and asthma control test score. These improvements occurred for both patients without food allergy and for patients with food allergy, with no statistical differences between the groups. In conclusion, from the collective body of evidence from multiple studies across different patient populations with asthma, with or without food allergy, we show that omalizumab consistently improved key patient-centered outcomes. Therefore, treatment with omalizumab may present a viable management option for patients with both moderate to severe allergic asthma and IgE-mediated food allergy. Thank you for your time.